Good morning, everybody. Thanks for having me. Today I'm going to talk about the top 5 things you need to know in 7 minutes or less. Just to remind everyone in the room, the goals of periprosthetic fracture surgery in the hip and knee. We want to have proper analysis of the implant to assess implant stability and function. We want to achieve a biologically friendly and biomechanically sound construct before we leave the operating room that allows us for immediate weight bearing, immediate range of motion. And again, to minimize morbidity, mortality, and reoperations moving forward in this elderly population. Number 1, fixing Vancouver B2s, kind of following up on EOA 2023 when Beth Gauzin and I talked about whether or not you can fix these alone. More and more literature coming out showing that for B2s, even when you show it's kind of or really loose, if you fix them or if you fix and revise them, the complication rates and revision rates kind of range around to be the same. So what should we actually do? A very simple algorithm to follow is the stem really loose. If the patient's very healthy, that patient should be probably fixed and revised for the best chance of stability and longevity. If the patient's really sick, infirm, and still want to mobilize, or if the stem is kind of loose, oftentimes when you go in, sometimes the lateral cortex, especially near the greater trochanter, can be spot welded, or certain areas of the stem is not completely loose. These patients tend to do okay with operative fixation with the same complication and morbidity and mortality rates as if you fix and revise those patients as well. Number 2, span the entire femur. This is not a new concept. Out of Pittsburgh, when Eddie Westrick was a chief resident, he published his paper in Core in 2014. Showing that if you protect the entire femur, you're going to reduce the morbidity and mortality of the second operation in this patient population as we try and minimize non-union rates and stress risers that create the next fracture pattern. So when it comes down to it, prevent the next surgery, whether you do it in Vancouver B1 and you want to go all the way down to the interprosthetic region of the anterior flange, or whether you do it in a B2 where you're going to fix and revise everything, make sure you're protecting the entire femur. And food for thought, maybe we should be protecting the neck. And when we're doing a DFR, in order to avoid this horrible complication and have to go through this surgery, which is awful, maybe even when we're talking about doing fusion nails, we should not leave the femoral neck unprotected, put 6'5" cannulated screws up there and make sure that for the next fall, our patient doesn't break her hip above there. Number 3, enhanced fixation in the trauma world as well as in ALCUS. Dual implant constructs around periprosthetic fractures in total knee are becoming more and more popularized when large metaphyseal zones of fracture and comminution above the knee, poor bone quality, when there's a THA above an interprosthetic situation, and even when there's a closed box, you don't have to do a nail plate combo, but dual plate combination can be very easily achieved here. And benefits of enhanced fixation, you're moving the neutral axis, you're allowing the stress transfer of the bone to experience stress from lateral to medial, and oftentimes you can win the race. These patients who are metabolically deficient osteoporotic bone, sometimes you need biomechanic stability to get a little bit longer in that healing period so that the callus can form without the fracture fixation failing. So dual implant constructs, whether you have native femur, again, span the femur, protect the neck, whether you have a Vancouver C where you get a nail plate combo and getting up all the way to the lesser trochanter where that has the best amount of bone, or whether you have your standard periprosthetic, if you have that large zone of comminution, you want to be able to protect the entire bone, move the neutral axis, and let this patient walk right away. This is something that our research group has studied extensively over the years. It's nice to see that other groups have been looking at this. This is a large multi-center study, a little bit lopsided in its combination, but again, 0 failure rates in this paper from JOT. The guys out of Alabama, whose BMI mean in this paper is around 43. Again, low failure rate with nail plate combination when it comes to isolated lateral lock plating. Number 4, on the horizon here, something that our group will be presenting at ACUS this year as a poster, which fracture patterns, which characteristics of the periprosthetic fractures around the knee oftentimes lead to DFR. Looking at our small database here, if you have a large vertical medial fracture that occurs on your CT, both on the coronal and sagittal planes, going from medial distal to the anterior flange. That is a poor predictor for fixation success, and you probably should think about a DFR. And if there are multiple fracture lines that consist of greater than 50% of the bone going into the total knee replacement, here's where you should also look at, consider DFR as well. Number 5 on the horizon, something that we're looking to finalize and submit and publish over the next 6 months. Looking at our retrograde IM nails, we actually assess the polyethylene and see how many times we need to swap it. My trauma colleagues at the OTA don't want to hear this because they don't want to look at the poly, but everyone at ACUS kind of says this is probably something we should be looking at anyway. Oftentimes we're swapping the poly about 35% of the time. We're upsizing it about 1.5 sizes, and the reasons for exchange is flexion instability. The PS poly is oftentimes blocking the nail entry. A damaged polyethylene or worn polyethylene is also not uncommon to see. So take-home points here, top 5 things you need to know. Vancouver B2s, remember if they're really sick or if they're spot welded, you can fix them. They'll probably do the same. Otherwise, if they're young and healthy, fix and revise, try and get the longevity out of it. Span the entire femur. God knows that when I'm on a plane going to the next meeting, I don't want a hip fracture above a DFR like that happened in that case I showed. Enhance your construct, whether it's nail plate or dual plate. Consider additional fixation for those patients to get them up, walking, and to win the race down the line. When you're looking at your periprosthetics, look at your CT scan. If it's over 50% fracture line going distally, or if there's that vertical medial line on 2 planes, it might be a poor actor you want to consider or have a DFR in the room. And when you're nailing retrograde for periprosthetic, please, if you're whether a generalist, a sports surgeon, or a trauma surgeon, get a good history about how the poly was functioning, and if it's in the way, have something available to swap it. Thank you very much.